Greetings from Malaysia, and a very good day to all attendees. My name is Fahli bin Sidek from the Ministry of Health Malaysia, and my presentation today is on establishing a national geographical disease surveillance system, practical steps for developing countries. So before we go further, a little bit of background. The Geographical Information System project at the Ministry of Health actually began in 2011 to map the distribution of Malaysia's healthcare facilities and overlay them with the population distribution. And in 2016, the Health Informatics Center integrated the GIS within a larger project called the Malaysian Health Data Warehouse, or MyHDW for short. So the MyHW is a national health data warehouse that integrates data from various sources to provide an analytical platform for the ministry to make informed decisions and effective planning. So the methodology of our study is based on a case study of Malaysia's use of the GIS for COVID-19 disease surveillance, whereby we outline the development, the data collection, the data validation, challenges, and solutions to these challenges in chronological order in the paper. So the solutions were built using the ArcGIS Enterprise platform. So based on our study, we found that there were several foundational layers for the geographical health system monitoring in Malaysia. The first one being the geocoding of all healthcare facilities in Malaysia to locate all the locations where healthcare services are being offered. The second one is the standardizing of boundary map layers for Malaysia to provide a common operational pictures for all stakeholders. Uh, by having these foundational layers, new information layers and dashboards were quickly created. And in the case of COVID-19, we were able to develop a national surveillance dashboard rapidly and to integrate with other sources of information such as logistics as well as international data sets. And we also use the data for public health risk communication via mobile application. So here are some of the visualization of the dashboard that we developed for our colleagues at the Crisis Preparedness and Response Center, CPRC, where we integrate the international open data set on COVID-19 case counts with the numbers that we have locally. And by capturing the data at the individual level, we were able to generate insights that would enable us to implement specific targeted public health interventions. So, for example, we can visualize, specific heat maps in particular localities, so as aggregate this information to the district level for operational use. And we also share the information where the data undergoes some transformation to mask the precise locations to protect patient confidentiality, but also at the same time share adequate information with the general public to know of nearby cases of COVID-19. So in conclusion, the cost-efficient and rapid development and deployment of COVID-19 dashboard in Malaysia can be attributed to the availability of granular patient data rooted in the principles of build once, use many that we use in the development of MyHDW with stringent safeguards for data security and patient confidentiality. So we hope that the principles and practical steps shared in the paper could be the basis for other developing nations who may wish to implement a similar national health GIS. Thank you very much for listening.